Hello, everyone, and welcome to today's webinar, The Opioid Crisis and the Role of OT. My name is Amanda, and I'm the Marketing Manager here at AOTA, and I'm going to point out a few things about today's presentation. First, CE. You can earn 1 CE contact hour for each webinar attended during Member Appreciation Week. At the conclusion of the webinar, you will receive an email from AOT Webcast containing a link to your CE certificate. However, you must stay on for the entire webinar until you view the pop-up screen that says the webinar is now over in order to receive your CE certificate email. You will have through December 31st to obtain your CE certificate. Next, questions. On the left side of your screen, you'll see an Ask a Question box. This is for you to type in questions you may have for our presenters throughout the webinar. Questions will be answered towards the end of the webinar, and the presenters will do their best to answer as many questions as time allows. And last, resources. The PowerPoint presentation for this webinar is available for download and can be found in the Event Resources box located just below the Ask a Question box. Simply click on the pull-down arrow to view the document and download. And with all of that helpful information, let me introduce today's presenter, Donna Costa. Donna?
Thank you, Amanda, and welcome everyone to this webinar on this incredibly important topic. I don't think we can open up a newspaper, magazine, or listen to a news broadcast that someone isn't talking about the opioid crisis. And so this webinar will give you some information that should be helpful to you in your practice and give you some ideas about the role of occupational therapy. So our learning objectives for today are to identify what are the signs and symptoms of opioid addiction. And this is in populations across the lifespan. We're also going to talk about the non-pharmacological approaches that OT practitioners could use for those who come to us because of pain management issues. And then we're also going to talk about the role of occupational therapy with the opioid crisis. In terms of terminology, generally the term opiates refers to those substances that are actually derived naturally from the opium poppy plant. That term can also be used to describe semi-synthetic derivatives. Opioids, on the other hand, are generally referred to as those drugs, medications, etc., that are fully synthetic and that mimic or replicate the opioid properties and symptoms. So examples of those would be hydrocodone and oxycodone, where examples of opiates would be morphine, opium, and heroin. Again, the effects are the same, and these terms are used interchangeably. So the first thing I want to point out is that the opioid crisis really presents 2 public health challenges. The first is the enormous number of people that are suffering from pain. The other being the harm that comes from using opioid medications, particularly in overdose. And so the current statistics are that every day in this country, more than 130 people die from overdosing on opioids. And that includes prescription pain relievers, heroin, and synthetic opioids such as fentanyl. This is a serious national crisis that affects public health as well as social and economic welfare. And the CDC estimates that the cost of prescription opioid misuse is over $78 billion a year. So that includes healthcare, lost productivity, addiction treatment, and criminal justice involvement. The CDC has noted that the opioid crisis is actually moving very quickly to a fentanyl crisis. And that stems from the increase in use of fentanyl, which is to blame in at least half of the opioid overdose deaths in 2017. Fentanyl, as you may know, is an opioid that's used for both pain and anesthesia, but it is 50 times more potent than morphine. And illegal fentanyl, that which is manufactured abroad, very distinct from the fentanyl that is prescribed and available in healthcare facility, it has a very potent synthetic form and oftentimes is cut with other opioids. So that can actually result in some unfortunate outcomes because of its concentrated effect and also low cost. So what do we know about the opioid crisis? We know that somewhere between 21 and 29% of patients who are prescribed opioids for their chronic pain end up misusing them. That means they could be taking more than prescribed, trying to get more medications than what is originally intended, or using them in other ways than prescribed. Somewhere between 8 and 12% of those people will actually develop an opioid use disorder. And again, some of those people who misuse prescription opioids will transition to heroin. When we look at people who do use heroin and we look at their histories, oftentimes they first misused prescription opioids, 80% of those. States across the country have seen dramatic increases in opioid overdoses. The Midwest part of the country probably being the largest area of increase, and more opioid overdoses occur in large cities, but by no means does that mean that rural areas do not see this. So this slide just lists the names, both the chemical name and the generic name of the most common opioid analgesics. And again, it's important for you to know what these are because healthcare providers, as well as the patients and clients we serve, are going to be using these as we take their histories. So statistics. More than 47,000 people died of an opioid overdose in 2017 alone. More than 2 million people in this country are addicted to opioids. And, you know, in terms of the pain parts, more than 50 million people suffer from chronic pain, 25 million with daily chronic pain, and they oftentimes do not have options other than these opioids for their pain management. But these statistics do not capture the full scope, depth, and breadth of the opioid crisis, which literally stretches across the fabric of our country, every domain of family and community life, and really puts strain on our healthcare resources, community resources, treatment centers, and emergency rooms. So how did this come about? Well, back in the early 1900s, there was a federal law, the Harrison Narcotic Act of 1914, and that really led both physicians and patients to being afraid that they would become addicted if they were placed on either morphine or other opioids. And so opioids at that point were used very sparingly. In 1986, the World Health Organization developed the first cancer pain treatment guidelines that included opioids for the first time, but also recognized that the treatment of pain is a universal right. The American Pain Society initiated a campaign called The Pain, the Fifth Vital Sign, which really became very pervasive throughout the healthcare community. And so by the 1990s, it was generally accepted that all patients throughout the healthcare system were entitled to an assessment and treatment of their pain. And this is actually a Joint Commission mandate that we evaluate and treat people's pain equally. So in the late 1990s, when the pharmaceutical companies started creating these powerful opioids, they reassured everyone that people could not get addicted to them. And so healthcare providers began to prescribe them at greater rates. But this led to misuse of these medications, diversion, and, 2015, more than 33,000 people died. But again, this number has simply grown as the years have gone by. OxyContin was introduced in 1996. Again, initially, Purdue Pharmaceuticals said that addiction was very rare. And we went from 670,000 prescriptions being written in 1997 to 6.2 million written in 2002. And remember, these prescriptions are written not just by primary care physicians, but also by nurse practitioners and then also by dentists. If you think about how many kids are prescribed opioids for their wisdom teeth extraction, it's very high. So turning to what population or populations rather are affected by the opioid crisis, we see now that it's everything from newborns up through older adults. And included in those mixes are people with chronic pain conditions, people with mental illness. So we're going to go through each one of these. And when we say children are affected, who? Well, we know one, that newborns are, whose mothers were addicted to opioids are born being addicted. And so they end up undergoing withdrawal themselves. Children across ages are at risk for accidental ingestion and inhaling toxic substances. Then we have kids who are living with an addicted parent or parents, dealing with the uncertainty that that provides. Many children have been thrust into the role of being the caregiver for their younger siblings because of addiction. Some children are removed from their homes, placed in foster care, or placed with grandparents, and many of these kids have unmet mental health needs. And again, we have to remember that very young children who are exposed to toxic levels of stress, we know the impact that that has on brain development. With newborns, the current statistic, and this has seen a dramatic rise in the last year, every 15 minutes, a baby is born suffering from opioid withdrawal. It was 45 minutes every 45 minutes just a year ago. So again, very dramatic increase in this. So this particular syndrome, NAS or neonatal abstinence syndrome, has been around since around the 1970s, again with dramatic increases in the last 10 years. It's caused by the sudden discontinuation of substances that the mother used during pregnancy. The occurrence ranges from somewhere between 55 and 94% of newborns whose moms were addicted or treated with opioids. So you might say, well, that's a very widespread. And yes, it is, but it varies based on what substance was abused, what other drugs were used simultaneously, how long did the use occur, and at what dosage. Treatment of NAS should be individualized, supportive, and at least initially non-pharmacologic. However, we know that 60 to 80% of newborns with NAS do not respond to non-pharmacologic treatment, and so they require medication, morphine, methadone being the two that are used the most. We also know that newborns with NAS are more likely than other babies who also have low birth weight and respiratory complications. So again, the rate of babies born with this disorder is increasing. You can see the increases from the year 2000 to 2014. These babies end up staying in the hospital much longer than traditional newborns, 2.1 days as opposed to 16.9 days. And of course, that drives up then healthcare costs to upwards of $66,000. So what do we mean by non-pharmacologic management of NAS? We certainly want to see a limit of exposure to lights and noise. Now in the NICU, that's actually pretty hard. We want to minimize handling. We want to promote rest. Music therapy has found to be very helpful. Massage, the use of water beds, swaddling and holding the infant, providing opportunities for non-nutritive sucking, paying attention to adequate nutrition to minimize weight loss. That means these babies need more feedings with high caloric and lactose-free formula, and volunteers need to be recruited to hold infants. One of the signs and symptoms of NAS is a very high-pitched cry. These infants are virtually inconsolable. And so it really takes its toll on NICU staff, where nothing will console these babies other than being held. And that's why volunteers in some hospitals are being recruited. So then turning our attention to another issue, and this has a potential role for OT, we're seeing studies emerge that parents of small children are not adequately locking up medications that are at home. A study was done showing that a very small percentage of parents actually locked up medications. And if you think about it, how many of us may have gotten a prescription for an opioid painkiller, didn't use it all, but hung on to it. It's still in our medicine cabinet. And that means it's accessible and available. And this is what happens in terms of accidental overdose. So the role that we have with prevention is making sure that parents know that they need to securely lock up medications, and that means putting a lockbox within a medicine cabinet, but also, educating parents about how they can get rid of old medications. Where are the medication take-back facilities, or what are the dates? So if you're working with parents who have small children, or if you are a parent with small children, there's a number of campaigns. There's posters that you could literally have in your clinic waiting rooms. You could have, videos playing in the waiting room so that parents gain more education about safe medication storage practices. And here's an example of a very brief video which was created. It actually is an animated video, looks at what opioids are and why you need to get rid of them and how you can get rid of them safely. So some of the other issues that present with children, some parents are using their children's pain to get opioids, actually using their kids to doctor shop, take them to emergency rooms to actually get opioids prescribed for their kids, which they end up using. We do know from the literature, data collection being done, that more kids are coming into hospitals with healthcare conditions already addicted to opioids. The opioid epidemic is burdening grandparents and the foster care system. And then poison control centers are being inundated with calls about kids ingesting prescription pills. And roughly at this point, every 45 minutes, a call is made about a child who ingested some prescription opioids. The large majority of those are kids under the age of 5, and with the next highest category being teenagers. So in terms of the impact on families and caregivers, we may turn our attention to helping care for those caregivers or grandparents. And you see a resource on this slide for an organization called Generations United. And they actually have some tips and strategies for caregivers, particularly grandparents that are now raising children because their own kids are either in treatment or have passed away due to overdose. Looking at adolescents, this is one of the fastest growing drug problems in the U.S. Teenagers report that they are very easily able to get these prescriptions right in their own homes from family members and friends. The CDC estimates that for every young adult overdose death, there are at least 119 emergency room visits and 22 treatment admissions. So again, the rate of overdose deaths among adolescents is increasing. And one of the problems that occurs in adolescence is that they can progress from their very first use of an opioid to full-blown dependence in a matter of months when you compare this against adults. Teens are often also believing that they're invincible. They think they can quit on their own. They don't acknowledge that they're dependent. They believe they're invincible and don't need either treatment or meds. And so there's devastating consequences for youth and their families, including progression to full addiction, psychological impairment, Hep C, HIV, exacerbation if they're also taking some co-occurring psychiatric medications, overdose, and death. So again, if you're working with parents who have teenagers at home, or if people in the audience have teenagers at home, you want to give a very clear message about the need to lock up meds. Kids are going to what are called farm parties. They literally will gather up medications that they find in their homes or maybe their grandparents' homes and bring them to a party, dumping out all these pills into a bowl, and then kids will literally just take a handful of whatever. So again, we've got to educate parents about the need to lock up medications, not to assume, oh, my kid will never, because they will at some point. Treatment of adolescents with opioid use disorder is difficult. It needs to be developmentally appropriate. You just can't take a teenager and put them in an adult program and hope that it's going to work. There has to be family involvement. There are not many treatment facilities in general, and even fewer for adolescents. And then insurance coverage varies widely. It's often hard to get these kids into treatment or engaged in treatment. And so if you are in a position to be designing treatment programs for teenagers, they have to be relevant, they need to be friendly, they need to be interesting in order to engage teenagers. This next slide has a very good intervention guide that you can download, and it has ideas in it of evidence-based interventions for infants, toddlers, children, and adolescents that are impacted by opioids. So if you're looking for some ideas, you're curious about what kinds of treatments have been shown to work with these different populations, I would encourage you to download this guide. If you are, if there are students in the audience that are going to be going out on field work, this is probably something that you want to download and have in your toolbox should you have any of this age group on your caseload during field work. People with serious mental illness is another population for whom the opioid crisis is quite serious. And there's not a lot of published research here, but a lot of anecdotal reports that suggest that up to half of the adults with serious mental illness in urban areas, particularly people with schizophrenia or bipolar disorder, are also using opioids. And of course, remember, they're already taking psychiatric medications, so now you're adding an opioid. And some of these, if they've been prepared synthetically, may be laced with fentanyl or other kinds of drugs. And so overdose and death are very common. Naloxone, which we'll talk about in a few minutes, is a drug that can reverse the effects of overdose, but it's not broadly available to people with serious mental illness, particularly those who are homeless and live on the street. Related to that is the suicide risk that the opioid crisis has generated. And again, when people have unrelieved pain that goes on for a long period of time, they do become depressed and in some cases suicidal, particularly when there is a lack of access to treatment. And so there has been seen an increase in deaths by suicide among people who have chronic pain and are using opioid pain medications. So we need, again, to educate people about how to assess for suicide risk, how to watch out for the warning signs, and how to really increase health professionals' knowledge of pain management strategies outside of medications. Women are another population for whom the opioid crisis presents a serious challenge. And the rates of both addiction and overdose are much higher for women than they are for men. Heroin deaths among women increased at more than twice the rate. An increase in the rates of opioid-related deaths in women has increased by 850%. Why is this? It's been suggested that women are more likely to experience chronic pain more than men. They tend to use prescription opioid pain meds for longer periods and in higher doses. And to add to that, the fact that this concept called telescoping, which is women who use opioids progress to dependence much more quickly than men. They have more cravings than men. And so, again, if you're working with women, if there are women in the audience, you have to know that this group is more at risk for developing addiction to opioids and more at a risk for death by opioid overdose. Older adults. We certainly know that our baby boomer population has increased. And remember that this group kind of grew up with the drug culture, if you will. So there has been an increase in the number of older adults who are using opioid pain medication. There has been research done looking at Medicare prescription drug claims. And in 2016 alone, this said that 1 in 3 people, older adults that is, who got a prescription filled by Medicare had a dosage prescribed that was higher than the manufacturer's recommended amount. Now, this may be because the older adult is saying to their healthcare provider, can you give me a 3-month supply instead of a 1-month supply because my copay will pay for it and it'll save me money. But that is risky because the threat of addiction in older adults is higher. We know that they have comorbid medical conditions, and so they can develop breathing complications, confusion, drug interaction problems, and increased risk of falls, all of which is going to put them in more danger. Again, continuing with older adults, we're seeing more hospitalizations for opioid-related diagnoses, more emergency room visits in the 65-plus age group, an increase in the rate of hospital stays, okay? So you can't assume, again, that, oh, my grandma or my older patients aren't abusing medication. They may not be intentionally using it, but they may be increasing the dosage because they can't get a handle on adequate pain relief. And so they continue to escalate their dosage. The other problem we have with older adults is they, more often than not, do not discard their medications. They hang on to them long after their need has passed, in case they need it in the future or a friend or relative needs it in the future. And again, then they have a holiday gathering or family comes over and now these medications are in the home, available to those who decide to look to see what medications might be there. Turning our attention to people with chronic pain, this is a large group, but obviously not the only group or population that is impacted by the opioid crisis. But we know that millions of people suffer from chronic pain. Only 30% of cancer patients get adequate pain relief. And if you think about it, pain is the #1 complaint why people seek treatment. And that can be for migraines, for back pain, arthritis pain, fibromyalgia pain, etc. But the healthcare costs for pain exceed $125 billion in this country, so quite high. So again, with people who are using opioid pain medication, we need to be familiar with assessments that will tell us whether or not our patient or client is at risk. And I'm going to share with you some websites and also some individual screenings. So this particular website and the link that you see on the screen takes you to the National Institute for Drug Abuse that's prepared a chart of a variety of assessments that you can use. And it's really good because they tell you what population it's for, adolescent, adult. They tell you what drug it can be used for. They tell you how long of an assessment it is, or is it just a very brief screen. So this is kind of a one-stop shopping assessment resource for you to use. This next slide shows a number of assessments that are available out there. The DAST comes in two forms, a 20-item and a 10-item. It also comes in both adolescent and adult and adolescent versions. And there's a variety of questions, but it really will help you determine how much of a problem the person's opioid use is. The CAGE aid is an expansion of the original CAGE. This is really a screening tool. It is a 4-item assessment. Very brief, could be used initially. Obviously, if you get a positive response to this one, you're going to want to administer further assessments to get some more in-depth tools. The opioid risk tool, this is an online screening tool that you can use. Again, it's going to give you information about how much of a risk to becoming addicted is this person. The CRAFT is an assessment that's intended to be used by adolescents. And so it has questions in there like, how often have you driven in a car with someone who is high on drugs? So it focuses on a lot of the behaviors that we tend to see in adolescents. This next slide has some additional assessments for substance use. And the first one is called the screener. It's specifically for patients with pain who are prescribed opioid pain medication. And so again, going to give you information on how much of a risk this person has. How much are they likely to start misusing the medication? The COM, or the current opioid misuse measure, is another one. Gets at rather the same thing. The pain assessment and documentation tool is a combination assessment and documentation tool that can be integrated into an electronic medical record. So for people for whom you're tracking their medication usage as well as their pain, this may be something very useful to you. And then the clinical opioid withdrawal scale is an observational scale that tells us how severe is the person's withdrawal. And again, we're going to be able to tell by just looking at them how severe it is, that it actually has 11 different categories on it of things that you're actually going to observe. So those are the assessments for substance abuse, the main categories of them. More and more are coming out with the explosion of the opioid crisis. So you may be wondering, if someone is in fact addicted to opioids, what treatments are available to them? And for the most part, it's medication-assisted treatment. And there are 3 federally approved medications that are used for opioid use disorder: buprenorphine, methadone, and naltrexone. Each one works differently. But there are limits on how much of these can actually get into treatment centers. And that's determined by some federal laws on the book, including the Comprehensive Addiction and Recovery Act. And this mandates what categories of health professionals can actually get a license and how much training they need. So you see on this slide, a nurse practitioner or a PA has to complete 24 hours of training. They can treat up to 30 patients. That's not very many patients. MDs have to complete 8 hours. Again, they can treat 30 patients. So just looking briefly at these 3 treatments, methadone is a full agonist. It works by changing how the brain and nervous system respond to pain. And so when methadone is used, it actually lessens the painful effects of opiate withdrawal. It blocks the euphoric effects. of the drugs such as heroin, morphine, and codeine. Methadone is offered in multiple formats: pill, liquid, wafer. It's generally taken once a day. But you can't get this from a private physician. You are going to have to be going to a methadone clinic. And so you're going to have to go there every day to get your medication. Pain relief from a dose of methadone can last anywhere from 4 to 8 hours. So essentially what methadone does, it prevents the highs and lows of drug-seeking behavior. Generally, people will remain on methadone about 12 months, although it can be much longer. And again, it can only be administered by a program certified by the government. So the next category is buprenorphine, which is a partial agonist. It doesn't produce euphoria, and it doesn't have the same side effects as other medications. So it does, in fact, lead to respiratory depression, but it is not as strong as heroin and methadone. The advantage to buprenorphine is that it is longer acting, so people won't have to take it every day. And it comes in pill, film, or implant forms. But again, remember, there's limits, and this can only be prescribed in an agency licensed to give it. Naltrexone is an opioid antagonist. It really blocks the effects of the opioids if used. So this is very helpful in blocking. In other words, if people take heroin, morphine, or codeine, they're not going to get high. There's no euphoric effects associated, no dependency issues. But they can't be started on this until they're off of opioids for at least 7 to 10 days. Usually they take this for 3 months. And the same medication can also be used for alcohol dependence. The forms include daily pills or an injection that lasts for a period of time. So recovery options going along with the medications can vary from inpatient to outpatient. Generally, detox is the first stage, and that will be an inpatient setting for 3 to 5 days. People will then move to partial hospitalization, where they'll go to a program 5 days a week during the day, but only for about 2 weeks. They will go home at night. Intensive outpatient will generally be half days, 3 to 4 days a week, for 1 to 2 months. So again, the medications are used with doctor visits, counseling sessions, drug screens, programming. Generally, there are recommendations for people to have to engage in 12-step programs like Alcoholics Anonymous, Narcotics Anonymous. What you do have to remember is that not all insurance covers inpatient programs or residential programs. The residential programs are probably the longest. Those generally are for people who've had several episodes of addiction. And so this can be very expensive to the individual. There is now a medication for overdose. I'm sure you're aware of this, and that's Narcan, which is approved by the FDA to prevent the overdose. It is an antagonist, and so it blocks the effects of opioids. It's most often given through an intranasal spray, but it can be injected into the muscle, put in an IV, or administered under the skin. This is going to very dramatically and quickly restore normal breathing to a person whose breathing has stopped. And our Surgeon General has actually encouraged all U.S. citizens to carry Narcan, that we should really think of it like an EpiPen or CPR. We know that a lot of the overdoses are occurring at homes, so certainly if you have someone within your family who does have an addiction to opioids, it probably would be a good idea to have Narcan in the house. And you may or may not be able to get that reimbursed through your pharmacy. Here's an image of Narcan being administered, and you notice it's just like any other kind of nasal spray. But again, we're going to see a very dramatic response to it being administered. So I want to talk about pain since, again, that is one main reason why people do become addicted to these opioid pain medications. And if we look at the definition of pain, it's an unpleasant sensory and emotional experience that's associated with actual or potential tissue damage. Pain is always subjective, so it's always what a person says it is. When somebody has chronic pain, generally they've had that for 3 months or longer. And chronic pain can come from an initial injury, but it also can develop without any clear cause. And generally it's going to cause mental health problems in addition to the pain issues. And it can often lead to despair. So most health professionals adopt a biopsychosocial model of pain, meaning that pain involves physiological, psychological, and social factors. However, these aren't in equal proportion. One person may have more of a biological component perhaps because of a medical issue. Other people may have more of a psychological because they have some ongoing mental health or emotional issues. And still others may have greater problems in the social context. So this model takes into account cognitive, emotional, spiritual, and cultural issues. Remember that suffering related to pain is an individual experience. So it's important for us to educate people about pain. And one of the concepts that doesn't explain all of pain, but that explains some of it and that patients can understand is this gate control theory, which has to do with our nervous system opening and closing to let pain messages through, okay? And again, this is a way of describing what happens with pain. So we can educate patients that there are factors that open the pain gate, which makes pain worse. And that might be the physical factors, like how bad is the pain, or is the person engaging in uneven activity levels, so kind of doing a sprint and then laying on the couch for 2 days. It can also be made worse by emotional factors such as depression, worry, fear, tension, etc. And then if the person is thinking about pain all the time, if they're bored because they're not moving because of pain, if their expectation is their pain's going to completely go away, and that's what they want from their provider, all of those things make pain worse. On the flip side, factors that close the pain gate and improve pain are things like medications. And remember, there are non-opioid pain medications, things like Advil and Tylenol, which, again, people who are addicted to opioids never think about using. Physical agent modalities, heat, massage, rubbing, those are going to help. Learning activity pacing, all right, energy conservation, those are important. And having adequate periods of rest. Relaxation plays a huge role in improving pain, as does the cultivation of positive emotions. This is hard. Some people, when you tell patients you can cultivate happiness and optimism, they may respond with, what do I have to be happy about? But it actually can help with pain. So it's worth educating people about this and being persistent. And then having people more involved in their life, being able to concentrate on things, to distract themselves from their pain, and to have positive thoughts and feelings. All of these are going to help. When we take a pain history, it really needs to be thorough. We need to find out what kinds of pain and episodes of pain has the person had before. What has the effect been on the patient? What kinds of pain control has the person found helpful or unhelpful? What is the person's attitude towards pain medication? What is the person's coping response for pain? What about their families? What are their attitudes towards the pain? How does the patient show their pain? and what is their knowledge level about their pain and their expectations about pain. So we often use pain scales, and we want to use ones that are brief and valid and that are validated. The most commonly used one is the numerical rating scale, the 1 to 10 or 0 to 10, but there's an over-reliance on this one. And so what we want to do is find out, how does this pain affect the person's everyday life and their quality of life? So does it affect sleep, mood, energy, their ability to engage in activities, socialization, relationships? Does it limit their activity or exercise? What about ADLs and IADLs? So we want to know, where is the pain? Where does it start? Does it go to other parts of the body? When the pain is at its worst, how bad is it? What's an acceptable level of pain, and what level is it when it's at its best? You want the person to try to describe the character or the quality of their pain and pay attention to the words they use. When is the pain at its worst? What makes it better, and what makes it worse? So here are some websites with some great resources. The first two, actually all the ones on this slide, are specific to children and youth. And they're going to give you some ideas about ways that you can help children, your own children, or children on your caseload with their pain. There are some great resources for low literacy patient education materials, as well as some specifically for neonatal abstinence syndrome. When it comes to pain assessments, we really need to have pain assessments across the lifespan. So here are three specifically for older adults. And we want to have assessments in the event that we have some older adults that are cognitively impaired. They're going to need specialized assessments. Patients oftentimes will be searching on the internet for help with their pain. It helps if you, as the occupational therapy professional, have some websites that you have vetted, that you know are good quality websites. And so the ones on this list are ones that I use with my patients, and that I have found to be very helpful. The one that's on here, the third bullet, the ACPA resource guide, is probably one of the best out there. It's 150 pages of things you can do for chronic pain management, and they update it every year. It's one of the best I've seen. So this next slide has some of the non-pharmacologic treatments from that there. The two that are not in that ACPA guide are activity pacing and energy conservation. So what can OT practitioners do? Well, you already signed up for this webinar, so that's great. Learning the facts about the opioid crisis, knowing the warning signs and symptoms, becoming familiar with assessments, speaking about prevention to your patients, family, friends, know where the treatment resources are in your community are, and advocacy, the role of OT in pain management. We certainly know that opioid addiction affects all aspects of functioning and performance, and we have important contributions to make. So there are some additional tools that we can download: the Opioid Overdose Prevention Toolkit, the National Pain Strategy, Relieving Pain in America. This is all going to give us more knowledge about what we can do about pain. As OTs, we need to know more about pain than we learned in OT school. And I would encourage each one of you to buy a pain book, take a pain course. OTs in both Oregon and Michigan fall under a new licensure law that requires all health professionals to take a course on pain management. You can actually access the Oregon one using the website that I have listed on this slide. But again, we all need to increase our knowledge of pain management and things that we can do in it, and be aware of what our distinct value is as an occupational therapy professional. Advocacy, I already mentioned. For those in the room that are educators, I think it is upon us to provide more education to our students about everything I've talked about today. There is actually a pain curriculum specifically for OT that you can find at the website on that page. And I managed to get through all these slides. My email address is on this slide, and we do have some time for questions, which I think Amanda is going to help me with, yes? Or am I just going to?
Sure. Donna, actually, if you want to just read the, start with the first question, just read it out loud and answer, and
sure.
just go down the list.
Well, I'm going to take the second one first. Which is more addictive, natural or synthetic? And the issue really isn't which is more addictive. They're probably both equally addictive. The problem with the synthetic is that they often may be laced with other things. And so that makes them potentially more dangerous. That they may have more euphoria associated with them and more respiratory depression. So that's the big issue there. The other question, how many of the prescription overdoses were for the person it was prescribed for versus illegal opioids that made their way into the drug market? And that's really hard to answer. There are so many different agencies tracking data on overdoses. They certainly have tracked the number of opioid prescriptions written in this country, but how many actually make it into the wrong hands, that's something that is not so easily recorded. Certainly they can look at emergency room visits, deaths, hospital admissions as a way of finding some of that out, but that isn't the whole picture. So the websites that I look at, Health and Human Services, the CDC, the National Institute for Drug Abuse, these are all reputable websites that track lots of data on an ongoing basis. And so if you're really interested in that, I would encourage you to check those out. The third question is a little beyond our scope. Is it true that combining an NSAID like Advil with Tylenol is an effective and comparable way for pain management? Yes, but remember, we can't tell our patients that. This is beyond our scope of practice. This is considered prescribing. So we can say to people, there are alternatives to opioids. You can talk to your healthcare provider about that. But we can't suggest that people use Advil or Tylenol as a way around that. With the non-pharmacologic interventions for newborns with NAS, you had listed minimal handling, but also swaddling, holding, and volunteers holding. What's the balance between those? I think the issue is handling that's not soothing, we want to limit. So swaddling, that's been used for drug-addicted babies for a long time. Holding. Typically, we will tend to pat an infant's back. You don't want to pat an infant's back with NAS. You want to rub their back. Again, because this has just emerged as an epidemic within the last few years, I don't know that there's any hard and fast rules. What the evidence says is you should pay attention to what the response of your infant is. If it's working, do more of that. If it's not working and the infant is inconsolable, then you stop that. Hope I covered. Why are they attractive to people who have no pain? That's actually a very good question. These opioids are attractive because they are very powerful medications that produce euphoria. They take away the unpleasantness of life. So if someone is struggling with depression, with a lot of crises happening in their life, and they take an opioid pain medication or just an opioid, they're going to feel better. Life is not going to seem as awful or as unpleasant. And so that's the power, more so than the pain relief. And so again, if we have to teach people that there's other ways to cope with mental health issues other than taking an opioid medication. Are diversionals effective? Yes. I mean, by diversionals, I'm assuming you're talking about other kinds of an activity than thinking about your pain, and absolutely. So we want to teach people, to use those things that actually are going to divert their attention so they're not focusing on the pain. Is there a difference between opioid dependence and addiction? Yes. There is within all of the addictions, people go from being dependent to full-blown addiction. That occurs over time. The difference with opioids is that the progression from dependence to addiction occurs over a much quicker period of time and less in some populations like adolescents and women. It is true that some chronic pain patients can safely take opioids for long term without abusing them. That is correct. But that's why we want to use those assessments I pointed out. And we may determine objectively that it's not a problem for this particular patient. They're using them sparingly. But it's the people who are doctor shopping, who are increasing their dosages, that's a problem. Is there more suicide from people who are being tapered off for chronic pain patients? I've heard stuff anecdotally as well. However, I haven't seen a clear research study that's pointing to that. Another question, a person is reading a study that involved people with mental illness who abuse substance use. That when people return to work, they change their substance use patterns around their work schedule, which inadvertently decreased their substance use. Well, that makes sense. And it's very similar to the topic we addressed a couple minutes ago about diversionals. When I'm focused on something at work, or I'm focused on a hobby, or on a social relationship or a conversation I'm having with somebody, my mind, my attention is being taken off my medication. So yeah, I can see where work would help decrease somebody's substance use over time. I think the role then for OT is, why does the person then even use after work? What other strategies could they use rather than resorting to substance use? Let me see if we have others. Students have had drug exposures and are now developing hand tremors. So I'm not surprised. There's actually very few articles looking at the signs and symptoms of drug addiction that maybe occurred in infants now showing up in students in the classroom. I think we're going to start seeing more of that. And I would encourage you to kind of record it and talk to other therapists who have similar caseloads or are in similar practice settings so that we can get a better handle on this. Do I have any advice for pain management when dealing with acute pain on top of chronic pain? Yeah, I think one of the things we can do is look at the meaning of pain to the person and their experience of pain. So there's a couple of very interesting assessments that I didn't manage. One is the pain catastrophizing scale, and the other is the chronic pain acceptance questionnaire. So this gets into people's experience of pain, and that has an awful lot to do with their usage patterns with medication. In other words, do they expect their pain to be completely taken away? That's an unrealistic expectation. But is it just an issue of, well, I'd like to be able to get on the floor and play with my grandkids? And I could do that with some pain, but obviously not pain so severe that I can't get up off the floor. What education would I provide to clients who are concerned that other providers encourage the use of Suboxone when it's shown I think if a patient is coming to me and they're concerned about something that a provider is saying or a practice that's being prescribed or a medication, to encourage people to get a second opinion and get some more education. I'm really not equipped to deal with answering a question about Suboxone. I think you mean Suboxone, Suboxone. And, all of these treatments for opioid abuse are addictive in and of themselves. So, there are some people that say we've just substituted one addiction for another. All right. I would love to go on answering questions for another hour, but our time has come to an end. I hope you found this useful. If you do have some specific questions, you have my email address. You can email me. I would strongly encourage you to download the resources that I shared with you. You never know when you will need them, and continue your education on this important field. Oh, there's an extra N in my email address. Well, that's unfortunate. Oh, and I can't go back on my slides. So it's donnacosta50@gmail.com. I'm not sure where the extra N is. So thanks, everybody. Have a great day. Bye now.